Welcome, everybody, to the Medics, Musings, and Mayhem podcast. I am your host today, Phil Aguet, generally and usually the man behind the man and the woman and the other woman. But today, front and center in front of the mic, representing all the medics out there doing it, grinding on the streets. And today I have a special episode for you. We're going to have an open, just free form, just stream of consciousness episode for you with the one and only, the man himself, Dr. David Collins. Sir, an excellent evening to you. How are you?
You as well, buddy. Good to finally get you on the mic yourself. The man behind the magic, behind the mask.
The wizard himself on the air. I think we should go back. So we're going to dial back just a little bit in, I don't know, late 2020 something.
It would have been April 19th, 2023, because I have the email up.
Because you have the email. I, out of the blue, by the way, live from Chicago, I emailed you and I said, what? What did I say? I don't even remember what I said.
Let me pull it up. I'm just going to pull up the exact wording because it's just too good not to share it again, right?
I don't know if it's too good, but I haven't read it in a while,
So the email says, Dr. Collins, I am a firefighter / medic / cop listening from Chicago. Stumbled on your show while shopping for foam podcasts. Absolutely love the show and the level, not too deep as to confuse, but deep enough on the science to push a bit. I'm also a professional voiceover artist. Your audio and editing were excellent. Podcasting can be a chore after a while. I was an early contributor to the EM Clerkship podcast. Keep it up. EMS needs more podcasts like this. Would love to help any way I can.
Yes.
And you didn't realize just how much of a mistake you had made.
Man, that was the landmine that I stepped on was huge. Okay. And here I am, chest deep in the Triple M podcast world. And we are, oh man, are we doing it? And listen, it's been fantastic. Now, I gotta say, Reagan and Livia, who are going to listen to this episode, you guys are hilarious. And you listeners out there, thank you so much. By the way, like, subscribe, 5 stars, and leave us a review. And please send us questions. We are out here and we're brainstorming different things to talk about. And rural EMS in particular, reach out to us. I want to talk to you guys. I want to see what's going on in your world in different places. Listeners from Alaska, listeners from Australia, if you're in New Zealand, if you're in Europe, wherever you are, we want to hear from you and we want you guys to reach out. We've been talking about this. We definitely want to talk about things that you guys want to listen to. So I reach out to Dr. Collins and I'm like, hey, and then in response, exactly what I wanted, radio silence for like 8 months, which was fantastic, right? So I think I sent another email later and was like, hey, hi, it's me again. Is your podcast still up and running? It's, I'm bothering this poor man. He's doing medicine out here, saving lives. And then we, the engine started and here we are, basically.
I will say that I think, because I have all the tabs up and it looks like you did help me with the CHF talk. And then we edited that. You made it sound magical. And they were like, this is great. We should do more of this. And then the radio silence happened just because life happens and my commitments piled up. And now we finally hit our stride, it seems like.
Yeah, no, it's really nice. And it's going well. And we have a team that we're building and we have visuals. And my wife is working on the website. And I think your wife is still editing. Is she listed as an editor still?
Yeah, I list her as an editor because she listens and then tells me if there's too many ums or buts, and then I try to make it sound a little less silly.
That's the best. That's the best. Chief Executive or butt officer. This is awesome.
Or just hey, that doesn't make sense. Why is that there? Change that.
Change that. So this is what we wanted to do. Okay. We wanted an episode. I wanted the origin story because what you listeners might not know is this man here is pretty darn amazing. Philosophically, education, his background. We're going to talk about it all. Why EMS? Why emergency medicine? Why care about paramedics? Why care about EMTs? Why care about rural medicine? We're going to get to the bottom of all this, okay? So the other night we had a conversation, a little pre-interview stuff, and I just asked one question. 20 minutes later, I was more fascinated than I ever have been in the I guess the now year, and I don't even math is hard.
Year and a half almost.
Year and a half almost that we've like corresponded. So, David Collins, where are you right now in the United States?
Where am I currently in the U.S.?
Yeah.
Okay.
Yeah, where are you in the U.S.?
So, primary location, places that I practice. So, my main place that I practice medicine 95 to 90% of the time is Ortonville, Minnesota. So, town of
small
about
place.
Yeah, town about 1,800 people. But when you start factoring in the surrounding communities and the catchment area, it gets, into the higher, double digits of the thousands, 10,000, 12,000 people probably in the immediate surrounding area. We've got some smaller hospitals here and there, but, Ortonville tends to see a lot. So that's where most of my time is spent. But I do have licenses in the state of Minnesota, South Dakota, and North Dakota, because as if I don't have enough on my plate, I like to do some locuming. I've done some really small ERs. I've done some level 1 trauma. I've done some level 2 trauma, and just because I need to get my adrenaline fix every so often.
Yeah, man. I hear you. Now, what people don't know is you are a board certified emergency medicine physician.
That's right.
You are one of the few in the area. Like, where's the next person doing EM?
The next board certified emergency medicine physician is probably in Watertown, South Dakota. And I would say that's about an hour and a half away.
Yeah. Yeah. And that's significant, right? We're talking about significant emergencies and trauma that, any human being can experience basically anywhere. And here you are. And before you, what was the setup? Who was doing it?
The setup at my facility has always been a family medicine model, which is very common for a lot of rural facilities. I think that hasn't changed. As far as the format goes, I think there's a lot of variety. So you might hear in some places, and this is where I've locum before, they do 36-hour shifts, like just 36 hours of nonstop ER coverage, and you're the guy or the gal that gets woken up every single time something comes in. Thankfully, at my shop, it was originally a 24-hour call, but once I came onto the scene, we switched it to 12-hour shifts. So you're looking at a primary care physician. So usually it's a family practice doc. Some places it's internal medicine. Some people it's surgery. It just kind of depends on the site and what you're capable of. And what basically how it works is that clinician is called over to the ER whenever anything comes in. Some places you're going to have a split of a clinic duty plus ER. Some people have ER only. In our shop, it's generally, if you're the on-call person, you cover any ERs that come in. You kind of have an urgent care walk-in clinic. And during peak pandemic, then you also had the privilege of fighting COVID for the day. So the amount of things that you could see could be crazy. Like, I think my record so far in one day is 36, including my respiratory clinic, urgent care, and ER patients, which is a lot of people to see in one day as a rural practitioner. But I would say overall the structure doesn't change, but sometimes the philosophy and the way to solve the problem is different. They talk about ER docs. We tend to think about worst case scenario first, and we work backwards. Primary care, internal med, they tend to think most common first and work towards the most scary. So just kind of some different philosophies there.
Yeah. So let's go back. You train where? Well, first off, you were a physics and engineering major?
I'll back up a little bit further. So I was born and raised in rural North Dakota, born in Fargo, lived there 7 years. And my dad got a new job, which displaced us into central North Dakota, town of I think 2,400, 2,600 at the time I was there, and did that till I graduated. And then I went to Bethel University in the Twin Cities, where I did actually start as a physics and engineering double major, and very quickly learned that I did not like math or physics nearly as much as I thought, and had some really challenging semesters where being the top of my class in high school to being not necessarily the bottom, but being someone that really had to struggle and really process because small town North Dakota doesn't have AP courses. So like all my classmates were napping because they took AP physics and AP calculus when they were in high school. So they didn't need to do anything. And I was trying to do calc-based physics as well as learning calculus at the same time, which was not ideal. So gave it a run, realized it wasn't for me, wound up in the psychology department where a professor fresh out of graduate school had finished his PhD in neuroscience. And that's how I kind of fell into, I guess, my original passion for human medicine. I guess the best way to describe it. Neuroscience is one of those things that I loved the way that my mentor described it. When I met him the first time to talk about neuroscience and switching, he looked at me and said, "Neuroscience is the bastard science." And I apologize for anyone that, naughty words, but that's what he said.
Yeah, folks, send your emails to Medics, Musings, and Mayhem, care of Dr. Collins, and we'll take your complaints. Here they come.
But it's a direct quote. But I like the way he phrased it because then he went on to explain that in neuroscience, the field developed because it took ideas from everywhere around it. So things like biochemistry, chemistry, physics, biology. Like when this guy built his own department, when I was there, he was borrowing like scraps from each department and building his own lab from those things. It was incredible. He was a brilliant, brilliant man. Dr. Adam Johnson, may he rest in peace. Phenomenal professor. And that's kind of where it started. Like just got me really excited about computational neuroscience, actually. So there's some math and some computer programming where I started. But I found as I got through my undergrad degree, I really gravitated towards biology. I really loved molecular and cellular biology. I loved organismic biology. I love biochem. And then I took neurobiology for funsies, which was taught by an OBGYN while I was an undergrad. I don't know how that worked, but he taught it from like more of a med student perspective, which I really appreciated because he kind of gave us a little teaser of what it would be like to be a medical student. And I thought that was super awesome. And that kind of wet the whistle more of like, okay, this is kind of the vibe I'm getting. I'm really liking the idea of applied human clinical science versus bench work. And I was going back and forth. I thought about PhD. I thought about going to medical school, applied for both, applied for MD, PhD programs, actually, which is a dual program. I was crazy back then. And the best thing that ever happened to me is that I didn't get in. It was absolutely devastating. I was crushed. It was really hard to go through, but it really opened a window of opportunity for me. Because that's how one of my buddies told me, hey, if you're still thinking pre-med, you're still thinking about going to med school, you should think about being a medical scribe for a while because you get exposure, you get to do some documentation, you get to learn the science a little bit, you get to learn the lingo. It's a great opportunity.
So for people that don't know, in the United States, you basically finished your college education and then you took I'm assuming some time to study for the MCAT, which is our entrance exam for medical school, which is no joke. Like one of the hardest tests you can take basically post university.
And they made it even harder than when I took it. They've added new nuances and facets
new
that
sections
I didn't have before. Just terrible.
And then so you do all this work, take the test, and then essentially get told no.
Yeah, you apply to your respective programs. You say, this is what my MCAT score was. Here's my resume. And they get to look through and say, based on their arbitrary criteria, yep, you meet criteria for an interview. You don't. I think the first time I applied, I had a couple schools that were interested, and I got a couple no's. And then I got you're on a wait list and you're number 75. And then I got on believe it or not, the only MD PhD program I applied to that I interviewed at, I got on the wait list and I was third in line. And they told me there is high probability you're going to get in because we usually go through our first 3 candidates just because they get an offer somewhere else. So I emailed those people religiously for months up until the first day that med school started because they're like, oh yeah, it's, no one's turned it down yet, but it's going to happen. It's going to happen. And finally that last email, they're like, yeah, sorry, this is the first year. Don't know how it happened, but we got both of our first 2 applicants.
Wow.
So 21, 22 or 20-year-old David is crushed, obviously trying to process this, well, what do I do now? I've never really encountered, I don't want to say failure, but like a setback. I've never had experienced a setback before, barring not doing well in physics and engineering. So this
Did
is
you
like
soul search? Did you reconsider? Did you like, you know what? Oh, this isn't for me. Whatever.
yeah, it was a lot because I'm thinking to myself, okay, well, I have a degree in psychology because there wasn't an actual neuroscience program yet when I was going through. I was kind of the pioneer to help create that curriculum because of the classes I took. I love my psych degree. I love everything I learned in it, but it wasn't a very marketable skill, or more importantly, the jobs that are open to psychology majors were not things that I was interested in. So then it was, okay, I can take the year and study for the GRE and then apply for grad school because neuroscience is an awesome gig. I could see myself doing that, even though, I don't really want to give up on this medicine deal. And that's when my buddy came along and said, if you're still thinking med school, why not, take the year, be a medical scribe, study for your MCAT again, and then just reapply? Because I bet if you be a medical scribe, that's going to give you some really good talking points when you're interviewing for med school. And I'm like, okay, well, that's interesting. I know. And then he was telling me about it and that he works in some ERs. And I said, I still remember thinking, ER, that's not where I want to be.
Not
I
that
don't,
place.
I at that time, like I'd had some experiences in the clinics and stuff because I'd been on like Accutane, so I had to get my blood drawn a lot as a kid. And
Sure.
I remember like nearly passing out several times just by watching. So I'm like, I don't know, like seeing other people's blood, like lacerations. I don't know if I could do that. That's
Right.
But if it's more like my gateway, I can get some terminology, I can learn some of the science, I can talk to some docs, get some like networking going. Then maybe I can get a stronger application. Let's do it. And so I wound up getting a job with a scribing company in the Minneapolis-St. Paul area. And I wound up at the Woodwinds Hospital in Woodbury, Minnesota. Awesome place, awesome docs I got to work with for that year that I was there. And then I also worked at St. John's out of Maplewood, Minnesota. Again, awesome docs. Like I had 3 or 4 or 5 that were like just fresh out of residency for a couple years. They loved having scribes. They loved trying to like get us like amped up for med school and like emergency medicine. And it's just funny, like looking back, just seeing the way the switch was flipped. Because when you start as a scribe, you got to learn the terminology, you got to learn the lingo, you got to keep up with the docs, you got to make sure the notes are done. So you're more or less stressed about just making sure you're doing your job and getting.
Now, for people that don't know, you're basically like standing behind the doctor as he or she is talking to the patient, and you're just like typing away or writing away.
Yep.
Right.
So depending on where you're at, it varies. But in my case, I wrote the HPI, the history of present illness. I did the review systems. Like all the symptoms they list, I'd be clicking on them, and then I'd be documenting their physical examinations. Like the medical decision making, the assessment and plan and discharge, that was the MD's job. But I did everything else, and so it was a very trial by fire, hands on experience. And after that initial like panic, where you're like, did I get everything, and did I get all the details? Because some of them are very picky. In fact, as a former medical scribe, I still have that PTSD because I'm very picky with my notes, and my med students hate me for it because I will pick their notes apart because detail is important, and it's important to write a narrative. That's a different soapbox. I will not get on that now. But when I finally got to that point where I had my rhythm, I was keeping up with people, I could start asking questions. I could start talking about stuff, and I could really start watching and like observing the medicine piece more. And what I loved about it, and this is where I got infected, punny, infected. It really started with just like the appreciation of like anything can come through those doors. Like one minute you're suturing a kid back together after falling off a slide. The next minute a guy's clutching his chest and is having an active STEMI, to going into the next room where, an elderly nursing home patient has urosepsis. Like I just love the fact that you could go to work and you had no idea what was going through those doors. And I think even like the camaraderie that as the medical scribes, at least when I was there, you had this very special relationship with the physicians and the PAs and the MPs, and you were part of their team. You were treated not as an equal necessarily, but you were part of their team because you were part of the documentation. They would sometimes ask those of us that were more experienced, like, what do you think? Like you've been watching this enough now. Is there anything else that I'm not thinking of that you would bring up, or something else I should do? And by the time you were done, like a year, I felt fairly knowledgeable. Like I don't, maybe enough to be like a 4th-year medical student doing his emergency medicine rotation. Like maybe that level is probably where I was at, or at least I knew where to start. And it would be funny sometimes because we'd have like the University of Minnesota med student who's just doing their little ER rotation, and they'd be pimping the student, and then they'd be looking over at us like, okay, what else do you want to do? And then you start listing all these other things, and the med student just looks at you like, I'm going to kill you. How dare you make me look stupid in front of this attending?
Sure.
It's like, no, like I'm learning so much by like watching what you're talking about and your interactions and what your opinions are. But this is what I know from my very limited scope as a medical scribe. I don't have much knowledge right now.
So yesterday we talked a little bit yesterday. This is like that part of the story where you develop this love, not necessarily for any one thing, but kind of like the emergency parts of it. Like you mentioned OB, you're like,
Yeah.
OB, but crash delivery, and it's like, now I'm in. This
Right.
is that little piece of it in the beginning where it's really acute.
Yeah. So, going into med school, so I got into the University of North Dakota is where I did my MD, which was great because that was closer to home. I could spend time with family. My initial thoughts when I went in was I'm going to do something like neurology or psych because that's where my training was. That's where my passions lie when I was in undergrad. But, emergency medicine was sounding pretty good. But, I didn't really know much about it. I hadn't really learned any medicine yet. Let's see how the first couple years go. And what I found was as I went through my third year, there wasn't really one place where I walked in the room and said, these are my people. There were elements of things that I liked. Like I loved the aspects of family practice because I did a rural elective, ironically, in Ortonville, where I work now. And I love the fact that there was that variety for them too. Like one minute you're delivering a baby, the next minute you're in the ER working up a chest pain, then you're back in clinic and you're, talking about diabetes management. Like I really appreciated the rural family practice element because one, I'm a small town kid, but two, as an old school FP, I think things have changed a little bit since then. The old school FPs had to know everything, or at least know a lot about certain things, or across a broad spectrum to be able to at least start the care for their patient. And if they need transfer, if they need that consultation, they can get the ball rolling then. So that was definitely something that really appealed to me. And I found myself at times during that FP rotation just loving the ER stuff. Like I told them when I was there for 8 weeks. I told them, you call me anytime after hours, I will come in. If it's a laceration, if it's a heart attack, if it's a trauma, I don't care. Call me in. I want to be at every single one. I want to present to whichever attending is on. And that's, I think, where it really started to grow on me in terms of like the rural aspect. I just love the fact that bad things, emergencies do not discriminate based on location. If anything, some of the craziest stuff happens in the middle of nowhere, in my opinion. And then you've got to really make do with what you got. So that was something I think that I really took away from that first year was like, I love the fact that rural FP has all this stuff. But I feel like if I were to really do this, I want to really understand critical care. I really want to understand like that upper level of what emergency medicine physicians think about. And so the rest of the year, like I love the pieces of neuro, love the strokes, love the, acute neurologic disorders, I love psychotic patients in psych. That was great. Like watching patients that just did not think normally was fascinating. That was something that I really enjoyed. So fast forward to fourth year, I've decided emergency medicine is probably where I want to go. And I was doing actually it was still during third year. I'm actually off of it. During my third year, I was doing my surgical rotation at the VA and I had to do some time with an ENT. Weirdest guy I've ever met. Really eccentric. But he was talking to me and he's like, oh, what you thinking about? What specialty you're thinking about? And I said, well, I'm still thinking. I'm not really sure. I'm thinking emergency med or like psych or neuro. Not surgery. No, not surgery, not ENT. No, thank you. But he looked at me and said, if there's one piece of advice I can give you, and I think he was trying to be funny, but I think there was a lot of truth to it, was if you want to pick a specialty, you got to pick whichever is the least objectable orifice. And it was funny at the time you laughed about it because it's just like, yeah, right. Sure. Do you like the ears? Do you like the nose and throat? Like in most specialties, you have to deal with one of those, to be fair.
Right.
And at the time, like when he asked me that question, I'm like, I don't really care. Like, I don't think there's anything that I'm absolutely off put by. Like, I'm willing to deal with most of those. But I took that into my future practice with my medical students. And instead of framing it like that, I said, I want you to look at your third year rotations, especially you newbie third years. And I want you, instead of thinking about this is the specialty I want you to look around and say, what do I enjoy most about these rotations? Like what was the thing or what was the feature of that rotation I liked the most? So like me as an example, I loved the stuff rural for FP. Loved like OB, C-section emergencies, preeclampsia, that stuff was interesting. Psych emergencies we talked about, like strokes are interesting, like neurologic emergencies are interesting. And even like the early surgical assessments I thought was kind of interesting. Like the actual procedures I couldn't get behind, but like chest tubes or like things you could do at bedside in surgery. Really like that stuff. I thought that was really interesting. So that ultimately is what led to me and my own little algorithm I developed for myself was I think emergency medicine is the best fit because I like a little bit of everything. the ER gets to give me a little bit of everything. And more importantly, I would argue that emergency medicine is hugely invaluable, not just to level 1 and level 2 facilities, but across the spectrum, especially like in critical access for sure. And so in my head, while I was, doing my auditions for emergency medicine for my rotations and wrapping up and getting ready for interviews, I was really thinking to myself, wouldn't it be cool if I could figure out a way to do rural critical care / emergency medicine and just have a gig like that where I could just basically be at a place where I'm the guy, or I'm part of a small group of people where we get to figure out problems with the least amount of resources and really get to play and really get to problem solve in real time. Like that was the thing that was in the back of my head. Maybe not as formulated as that, but I think that's really the kind of the heart of what was in the back of my head when I started. So fast forward, graduate from UND, get matched at the University of Missouri, Columbia. So I got to go to Columbia, Missouri for 3 years. Go Tigers. And by far was exactly where I needed to be. Like I had the most incredible class of co-residents. They are all over the map right now. And we all do very different things. But even like our upperclassmen, when we came in as interns, were just instrumental for like my education, for my understanding, learning the tips and tricks of procedures. Like I just had an incredible group of people, an incredible group of nurses, techs, EMS crews. Like I was really blessed. Like we were just like a giant family for those 3 years. And it just really solidified for me. Like these are my people, like hands down, these are my people for sure. Fast forward to being done with residency and not having told a soul at that point that, yeah, I'm going back to rural Minnesota. We're going to see if we can do rural emergency medicine because it's not been done, or at least publicly, no one has said, hey, I do rural emergency medicine. You should all give it a try. And I remember just getting the look on just various faces from my classmates or from like the nurses. They're like, you're going where? You're going to be so bored. Those are the most common responses I got when I've told them that I was going to be doing rural emergency medicine in a town of like 1,600 people with a somewhat sizable catchment area. And I'm like, well, maybe I'll think about doing a little bit of locums on the side, and I can go find like a level 3 or level 2 somewhere, and I can get my adrenaline fix. But I really want to give this a shot. I think it's going to be a sweet gig. I think it's worth trying. No one's done it before, at least no one that I had seen talk about it publicly. I think not too long ago, Rick Bucata did a piece on MRAP about emergency medicine being more active in the smaller emergency medicine settings. And I don't remember hearing any feedback from the community on that, but I thought it was a great piece. Like I was totally in agreement with the stuff he said during that.
For those that don't know, MRAP, fantastic, not even like a show, more like a sphere, a universe.
Yeah.
Where they cover critical care and emergency medicine stuff. They also cover urgent care issues, which I think is actually really applicable to EMS. I listen all the time to the grand rounds and just like listen to these high level, very experienced docs, some from my hometown back in LA, like talk about these presentations. But really cool. If put that on your list of things to listen to. There is a piece that you have to like sign up for membership, but their podcast stuff, and if you sign up for their emails, their live streams are totally accessible, and it's really great. I'm like, you're right in the middle of these deep discussions. Pretty sweet.
Yeah. It's something to aspire to for us lowly podcasters too, but to be at MRAP level, you need like an army of people to do it. You got to stand on the shoulder of giants somehow.
That's right.
That they were definitely an inspiration for even trying to kickstart this bad boy when we first started talking about it.
Yeah. So what you mentioned there is I would assume anyway, a typical kind of response. Like you're not going to, shock trauma in Baltimore. What are you talking about? Like, what, why aren't you going to a high level place? Like with people, Chicago, Cook County, Northwestern, University of Chicago. Why aren't you going to, New Orleans or something where you're going to be a big time, big shot EM doc? And here you are. And you're like, no, I'm going to take these skills back to the rural setting where they are desperately needed. Because this is a thing we didn't really talk about yesterday. It was like rural places in the United States. The expectation is that most people that live in urban environments like me, like you call 911, here comes the cavalry, and they're here within 5 minutes. And that's, for the most part, the 911 part anyway, the same across the United States. At least the aspiration is. But the 5 minutes part is not true. And where they take you may be, the first place out of the next 3 that you have to go to really get like super definitive care, and they may not meet a Dave Collins emergency medicine certified, guy as their first shot. It might be a first responder. It might be their entrance into the system might be an EMT basic that's a volunteer. So for all of you folks that are listening in other places, like not in the United States or in urban areas, you don't know much about the rural setting, like this is a problem for the United States. We're up against and have been for probably the last decade, a decline in volunteerism, both on the fire service and in EMS, and this sort of need to pull physicians, to pull nurses, to pull APPs and PAs into the rural setting. And the cities are still sort of, they're magnets for people coming out of school. So everybody kind of goes to these big urban centers. But you did the opposite, counter. You went against the grain, and here you go. And people are looking at you like, what are you talking about? And you did it anyway.
Yeah. Just to take a moment too, I don't want to diminish any of my colleagues in family practice or primary care. Like they do a great job when it comes to managing their patients. Because quite frankly, a lot of the folks that come into their ERs are people they know. They're either their primary patients or they've taken care of them before. It's a teacher, it's a janitor, it's someone they know in the community. So I think that's something that's very unique to rural emergency medicine, because I think having that rapport is really important. And I would argue that for some of these places, they would probably trust these FPs more than a board certified EM doc that comes in and out. But I would say that the important thing to keep in mind is that our training is different. Most family practice residencies, I think in general, have like 1 or 2 months in the ER, and that's it. So they don't really have a lot of more dedicated time to be like, this is the main difference for a workup in the ER for chest pain versus what you might do in the clinic, for example. Like the algorithm changes. And I think the other thing that was really interesting when I first got here is that I was able to provide unique ideas that were either not thought of or people didn't feel comfortable with. So going with the most obvious one, ketamine, right? Like I will freely admit that I'm a ketamine evangelist. I was converted by one of my numerous colleagues at Mizzou, but there was some hesitation and fear of ketamine being used outside of the OR. And we have 2 absolutely wonderful nurse anesthetists that do a lot of the surgical stuff when outreach comes, but they don't feel comfortable doing things like procedural sedations and whatnot outside of the OR because that's not their area. That's mine. And so there were a lot of conversations that had to happen about, well, here are the numerous merits of ketamine, not just for intubation or for like uncooperative patient. And so we got to start with building a order set. This is how we're going to calculate. This is how we're going to dose it. And then I got the privilege of starting to teach the nurses, this is how ketamine works. And when I still remember the first time we pushed it, I think it was on a kid for like a reduction or a laceration repair because they were just not having a good time. And my nurse looked up and she saw the blood pressure shoot up. She saw the heart rate go up. And I looked at her and I said, that's normal. Like that. And you're going to see that. That's going to be there. Keep watching the oxygen. Let's make sure they're still breathing okay. And by the time we were done, she's like, this is the best thing ever. Like we didn't have to like torture the kid. We didn't have to pin them down. You got to do everything while they were out. I totally support you now with this ketamine. I think that's something that as an emergency med doc that comes into a critical access or a lower acuity hospital and you just say, well, have you thought about this? Or here's what the data shows about VBGs versus ABGs, like having those conversations, because as much as we love our FP docs, like they don't have that type of research because they don't have the context of the ER a lot when it comes to family practice journals. So I get to be able to bring these ideas forward and say, have you thought about this? We should really revamp our behavioral emergencies protocol because the current medication list, it's not going to work. It's not going to keep our nurses safe. It's not going to keep our paramedics safe when they come in. Like we need to do better with that. Like those are just 2 very extreme examples. But I think that's been something that's just been so cool looking back over the last 4 years is that I think that our care in the Ortonville Area Health Services community has jumped ahead multiple years in its understanding and management of the ER because of that.
You sound like you had an impact as soon as you get there. But what's missing from this story is if I change the location to like, oh, Dave Collins came to Chicago and he had ideas, the bureaucracy would have slapped you right in the face. Like it would have basically told you no. And thanks for playing.
Or they would have said, write an S bar and we'll get back to you. Like that's
right.
That's usually how these things work. And this is something this is my own personal preference. And this has to do with your personality when you're thinking about jobs, is that I wanted to work at a place where the number of suits didn't outnumber the number of medical staff, basically. And so, we have a CEO, we have a CFO, we have a CMO, probably a couple other letter combinations I don't remember. The difference is that our CMO, who has now been advanced to the CEO position, is a physician. So I can go to the CEO with an idea and say, hey, this is my idea. What do you think? Well, give me some data and give me some information. Let's talk about it. Like, let's figure this out. When I finished my point of care ultrasound elective, or excuse me, not my elective, my fellowship through the Ultrasound Leadership Academy, I went to them and said, hey, I have a new marketable skill that if I keep working on it, we can bill for this. Can I get some additional assistance so we can have a system in place so we can start billing? And, when you mention possibility of making more money, then they're all ears and they're all for it. This allowed me to open the door for additional discussions of like, hey, what do we need to do to get an MRI? What do we need to do to get our techs more comfortable doing more CT angiograms? Because when I first came there, they actually drew it out for me. The number of CT scans skyrocketed exponentially by the time I got there, because
Wow.
I was much more quick to order CT scans. And my techs will speak to this. Their comfort level with CTAs of the head and neck for like stroke protocols jumped very quickly, because I was one that I didn't like doing the non-contrast head CT only unless I was certain this was more of an intracranial hemorrhage. And most neurology programs at big facilities are doing CTAs. So why should I just not start at the beginning and go there? So the radiology department, their comfort level jumped by my coming there, because I was willing to just say, we need to do more of these scans. This is what we need to get the best care possible. And that really changed the radiology's culture, just because we did something like that. Telling the lab techs like, hey, you don't need to worry about ABGs anymore, because the VBG data is just as good in most cases, barring some very unique situations. And they absolutely love that. So like they dreaded ABGs. And then when they
Yeah,
found
sure.
out that, Dr. Collins is able to do ultrasound guided ABG collection, even better. Like, we don't have to worry about like blindly poking or sticking anymore. And this is just looking back over 4 years. I think it's easier for me to look back now and say, man, I really made some waves. But at the same time, like, I came in as a kid that thought he knew it all about emergency medicine. There's probably a little bit of ego there, but I think that there was some growing pains and some learning pains for both sides in that case. But I think that we've all come out better for it just because of the opportunities that we had.
I mean, just in the way that you admitted that right there, like, this is the type of conversation I think we all need to hear. We're sort of, physicians and culture are placed upon this pedestal, and we don't often hear people go, yeah, I maybe was a little bit cocky when I came through and I learned some stuff. I made some mistakes. Like, those things are okay. And particularly okay when you take a 3-month EMT course, or you do, like a year of a paramedic course, maybe even correspondence, and you're out practicing the day after you graduate, expected to kind of know everything all at once. Just kind of switching gears to like EMS. You weren't an EMT or a paramedic, right? Like, at no point. And so the first time you're on an ambulance is when?
First time I was on an ambulance was when I was an intern in residency. That's where my first interaction started. And I have to say that just doing that alone gave me so much better appreciation, one, for what our brothers and sisters in the field do. Like, the things they go to, the things they respond to, the situations that unfold before them. That is wild. Like, I have the beauty of the confines of my little ER, my little box with my nurses, and I can tell them to do stuff, and it works nicely. But to see things these folks did was incredible. Shout out to Chris LaRue and Brandon Waller. Like, those two guys, I just requested shifts with them when I was on my intern part of my ambulance rotations, because I learned so much from those two, just because of, like, one was really calm and quiet. The other one was kind of more of a loudmouth, kind of speak how you see it, but he was always very polite to his patients. Like, he would just be one that would just kind of redirect them and remind them, like, nope, we're not going to do that, or we're going to sit still, and they were just very quick to being willing to teach, because, like, I had so many questions just about, like, how do you guys do X in the field compared to, like, what we do, when we're in the ER and stuff. And the beauty of that was they were just so approachable that one of my things when I finished that part of my rotation was, I'm going to go into the ER. I want to know every name of every paramedic and EMT on our service, so that when I see them come in, I can greet them by name and I can hear what's going on. So we have that degree of respect and understanding. And
Can I
that
just pause? Can I just
yeah.
pause right there? if you're a med student or you're an intern or you're a resident, from the medic's perspective, that is huge, right? Having that relationship with the physician that I'm handing care over to and being able to have the comfort to be like, hey, you know what? I think I know what was happening here, but can I clarify a couple pieces with you? That's huge. And that ability to build that trust between the two, roles is crazy. And it's what else is crazy is how little that is pursued in some areas. Because I tell you from experience, going to a place where you drop off, where you sort of transfer care, and it's as if they could have showed up in an Uber for all the information that I have and I'm trying to give to the team. It sucks. I mean, there's no good way to put it. And then in other, scenarios where that relationship and that trust is there, the satisfaction of, hey, I did what I did. I got them out of their situation. I stabilized them. I have all this information and all this initial sort of assessment done, and it being received to a person that knows me by name is crazy respectful. And it just makes me sort of want to do even better next time, right? I have, shout out to Dr. Jaramillo, shout out to Dr. Angel, to Dr. Chun. These are folks that have taken that same philosophy and said, hey, listen, I'm going to build a relationship with these people and have a conversation with them every so often like human beings. That's so cool.
And I think it builds so much more rapport too, because I can think of times where one of the paramedics and the EMTs come in, they have this patient, they're crashing, they look like garbage, and you're doing all these steps, and they got to go because they got to go take another call. But to have them come back and say, hey, what happened to that one person that I brought in? And you can tell them like, yeah, we did this, this, and this. We got them back. And they're just like, yes. Was there anything I could have done differently? And that's their immediate next question is like, what could I have done differently? And to be able to teach both ways. Like I can teach them like, these are the things that you can do. What's your protocol say? Like, what are the steps that you can do? Okay, perfect. Let's talk about that. And it can go the other ways, because then if I have someone come in, I'm like, well, why didn't you do X? Because that could have been done in the field. Well, that's because our protocol doesn't allow it right now. Like that, being able to have that two-way communication just elevates patient care in ways that I cannot emphasize enough. And I think it was illustrated further from me being an intern to a second year when Dr. Josh Stilley, shout out to Dr. Stilley, took over a lot of the ambulance services for Mizzou, because the way he just rearranged things, changed the protocols, changed the culture for the paramedics. Like they were great before, but like it was just kind of like a big family by the time that we were second years. I knew everybody by name at that point. It just made me want to go and do my EMS elective as a third year, which then allowed me to do 4 weeks of ride-alongs, riding in quick response vehicles, being on the scene, talking about protocol changes, teaching EMTs and paramedics. Like it was a blast. And it just kind of let me get to come back and work with some of the same guys and girls that I'd worked with before, but have so much more to bring to the table for them, because now I had 3 years of emergency medicine knowledge compared to the borderline medical student / intern who was just starting emergency medicine, who didn't really have a lot that they could say confidently compared to the third year senior resident in emergency medicine. So there was definitely a lot gained from that. And I think that's where like the EMS bug, if you will, kind of worked its way into my system.
So fast forward a little bit, here you are, and you're now medical director for like a few different services, right?
Yeah, I think I'm up to 6 now.
Six different services and all different levels.
Yeah. So the main ones I work with, and just for the sake of, anonymity and privacy for services, I've got the 3 that are in my immediate community. They're all ALS, BLS services. I work with a first responder group in one of the adjacent towns that just wanted some further guidance and actual protocols to guide them, because they had no protocols as first responders. They wanted like some degree of guidance. So I slapped together some protocols. I actually was just kind of tongue in cheek, put on their insert witty name and super cool logo here, thinking that I'd get an email back and we could talk about the protocol some more. Nope, they printed it off and they ran with it and they think it's great. So if the assessors go in there and start looking, I really hope we get that cover page taken out. But like the feedback, once I finally reach out and say, are things going okay? Like, did the protocols help? Like, do we need to change things? Like, no, these are great. Like, we had nothing before. This is fantastic. I've got a BLS crew north of us, and then I just recently acquired another BLS crew in an adjacent town. So, like, it's just one of those things where it started small. Like, I literally just had the ALS BLS crew in my town that I practiced, and it just kind of fanned out from there.
Now, you're the EMS medical director. You're running all these services, you got all these protocols, you're bringing new things into the hospital. It's not enough. You decide, I'm going to start a podcast and I'm going to talk directly to these rural EMS providers. And you basically sort of are like, yeah, I'm going to talk to the folks kind of in my area. And here we are, we're getting emails from like all over the world.
Yeah.
What is happening?
I mean, we kind of teased out a little bit early on. So like the original purpose of this podcast was to make it easier for rural areas, right? Like the biggest challenge for rural facilities is that a lot of them are volunteer. A lot of them have other jobs and other commitments. So it's really unfair to expect the whole cohort to show up for a mandatory 2-hour meeting to read through a sheet of paper. Like if I had to do that in residency, I would be like gouging my eyes out by page 2 because it's too much. It's just a bunch of word vomit. Where are we getting anything from this? I had actually just taken the NAMSP medical director's course because I wanted some more guidance on like the stuff that you don't learn in residency, but it's more of a condensed pseudo fellowship in many ways compared to the fellowship that's devoted to emergency medicine programs. But as I was like sitting through these different classes and them talking about different ways to like elevate your EMS services, I'm like, a podcast is a great idea because then I can update my protocol or rewrite the protocol, do a podcast on it, and distribute it to my paramedics and EMTs. And then when we have our meetings, they can come with questions and say, hey, I listened to the podcast on anaphylaxis and I have a question about X because I heard you say this, this, and this, but can you expound on this more? I feel like that is way more worth my paramedics and EMTs' time to talk about the important things that they're curious about versus going through a bullet pointed list about what to do next. I think it's just been way more beneficial. I think it's gained a lot of traction across all age groups. I've been a little bit surprised. But the younger generation loves it because then they can drive and they can listen to it. But the older generation's right there too, like, oh, this is great because I can just click and listen to it. The next time we have like a run review, I can ask questions. Or the other thing I've noticed is that they come into the emergency department more prepared to talk about what they've done. They are now feeling more comfortable. They get to own the protocol because the protocol is written by me, but I still have every single service look it through and say, this works for us because of X. We can't do this because of Y, or how can we compromise with Z? And as a result, I'm hearing more and more about, hey, your paramedics came in, they were more prepared, they were able to explain what they had done, they were able to clearly expound on what their concerns were. And
You talked about this yesterday. This idea of owning your protocol and really understanding what was happening. And you made a quote that you had a quote that I love, that you shouldn't have to hide behind your medical director. That being empowered and being able to understand what it is you are doing in terms of your protocols and your practice gives you the standing to, when questioned by someone, explain what it is that you do and why.
Yep.
And that's huge.
And I think it's a bigger problem in rural communities based on my experience. So accumulating or acquiring some of these services, hearing things like, we haven't seen our medical director in 5 years, or they came and they signed paperwork once and they left. That generates a culture of fear, in my opinion, not necessarily of the medical director, but we don't have someone that's clearly coming to meet us, to advocate for us, to get to know us, to talk about what we think we need to be better. That's, I think, one of the reasons that really spurred this podcast forward. And then, once you reached out and said, hey, this is great stuff, and that I think this is a niche in EMS that doesn't have anything out there. I think that's what really drove this, because the more I interacted with rural services, not just in Minnesota, but in South Dakota, North Dakota, and just hearing the same thing, like we just don't understand, or we just do what the protocol tells us. Well, then you ask them like, well, how long ago was the protocol written? 2010. Okay, well, did you know about X, Y, and Z that are new recommendations? No. Well, when's the last time your medical director has reviewed your protocols with you? They haven't done that before. Like things like that are really sad for me. But then I also understand, again, being a small town kid, these poor primary care docs have all these fires that they're trying to take care of. And then on top of that, they've got this EMS director role that some of them do enjoy it. Like I know of some that do a great job and they love EMS, but there's other ones that I had to do this because there was no one else to do it. And so I'll sign off on the meds, I'll sign off on the protocols, I'll sign off on the run reviews, but don't ask me to explain to you X, Y, or Z. And I think that's a big disservice to our paramedics, to our EMTs, to our first responders. I think that knowledge is power, but we also need to know what our limitations are. And how are we going to learn our limitations if you can't approach your medical director and say, hey, I'm worried about intubating, or ketamine is scary. Like I hear all these things on the news. Why are we using ketamine? Or we brought this patient to the ER the other day and we gave him D10, on a drip, and the receiving facility yelled at us because we didn't give him an amp at D50. These are things I think are easily correctable. These are things that I think we can empower our paramedics and EMTs so they can comfortably say, well, according to our protocols, this is why we do this. And furthermore, we know that's the case because of this pathophysiology, this step, and this step. And if that's still not enough, then my role as medical director is to step in and try to assist them to alleviate any further tensions so that this doesn't happen again. I don't think that paramedics or EMTs should be afraid of their protocols or be afraid of going into a facility that's receiving the patient and having to defend themselves or to just say, well, you need to call my medical director to get that question answered. And I've had conversations with several of my paramedics and EMTs where these things have happened and they did a great job. And once the conversation was over, the physician was satisfied with their answer because they explained their rationale. They explained the reason they did X, Y, and Z, and the evidence was there for them to back them up. And that's my job, is to help them own their protocol, to own their skills. And if they want to learn new stuff or want to try new things, let's do it. Let's see how it works. Let's talk about what might be safer, what's not. An example is, which we've talked about in the podcast a lot, is what purpose does point of care ultrasound have in the rig? And I fall in the camp that it belongs there, but we need to talk about when is it acceptable practice versus when is it a shiny thing that we need to put away. That's the thing that I think is lost in rural EMS medical directorship.
I'm going to ask you some questions.
Okay.
Just some fast fire questions here.
All right.
Right. Here's a quote. Here's a quote. Here's something we hear often in EMS. Learning new stuff is great and everything, but it's not going to change my care or my practice. I wouldn't have done anything differently. I'm still just going to follow the protocols. So what's the point? What do you say to folks that are on the sidelines for whatever reason? They're burnt out. They're a little bit jaded, and we need to bring them back. Obviously, we need to bring them back into the fold here. But you hear this a lot with people. It's like, why do I need to understand that deeply? It's not. It wouldn't have changed what I was going to do based on the protocols.
Mm-hmm. I think my first question, especially like you said, for the folks that are burned out, and this is, again, thinking more in the context of rural because that's what I do. My first question for that individual would be, why are you here? Like, what is it about doing this job keeps you here or keeps you going? Because I'm willing to bet that in 75% to 90% of those individuals, it's because I love my town, I love my community, I want to take care of them. And if that's their answer, my next response is, then don't you owe it to your teacher, to your neighbor, to your classmate from high school to give them the best care possible? And I feel like most of the time that really kind of helps alleviate that. If it's something more related to like the hours or meetings are too long or something like that, let's talk about it. Let's figure out what can we do to make this job palatable again. And I think that's something, again, that as a medical director, I can make this job a lot more fun for them by just being present and just trying to figure out ways to make this better for them. Because I think the worst thing that can happen is a paramedic or EMT says, I'm burnt out, I'm frustrated with this protocol. And the medical director says, oh, okay. Or, well, that's what it is. I don't really think I'm going to do anything about it. And again, these are just generic examples. I'm not calling anybody out. There's really no one I'm thinking of when I say these things. But these are the perceptions that I've heard from EMS, from different towns and different states, is that this is what they perceive when they're talking to their medical directors. And I think that they deserve better, and we owe it to them to treat them with more respect and to give them more confidence in what they're doing.
There are definitely probably some folks listening who are considering maybe going into EMS, and their first step is going to be either a first responder program or maybe an EMT program. And you do a little bit of training, you get a little bit of knowledge, right? It's actually super important knowledge for any of you folks that are EMTs considering paramedic school, or you're considering EMT school. Like, just so you know, those same assessment tools that you are trained to use in your EMT program, you use that at every single level. I am halfway through nursing school right now. I'm going on to be a nurse practitioner after this. Dr. Collins, all the way through medical school. The assessment, the ability to connect with somebody, to pull that history out, to decide whether or not someone's sick or not. Like, those are the skills that start right at the very, very beginning. But to those folks, Doc, they come out and some of them are like, I have a little bit of imposter syndrome. I don't actually know what I am doing. What do you say to those people?
Join the club. First of all, it is totally normal. Like, let's just say that right up front. And it's so cliche, but I want to just reiterate how normal that is, because from someone who went through medical school, you feel that way as a med student, you feel that way as an intern, you feel that way as a senior resident, and you feel like that as a baby attending. Like, that feeling never goes away. And more importantly, it shouldn't, because that is going to keep you humble and it's going to keep you hungry. Because if you don't feel like you know it all, you're going to look for the answer and you're going to figure out ways to be better at it. So there is nothing wrong with the imposter syndrome. I think the more important follow-up question is, what are you going to do about it? So like you said, like, let's say a brand new paramedic is out and they are in a facility where they've never been before. It's a small one. They're just like on their first shift. And it's like, I don't know what's going on. Number one, find a mentor. If that means a paramedic at that group, or if you got a paramedic that you, or like an educator that you had when you were taking your classes, or, you know, when you were shadowing somebody, like, find someone that's going to be your mentor. I recommend one that's at your level for sure, like a fellow paramedic. You know, having a medical director as a mentor is never a bad idea. You want to be able to express your true fears and frustrations, right? Like, I think the biggest mistake is bottling it in, just to, like, fake it till you make it. There's some truth to that, but at the same time, like, we're talking about people's lives here. So we don't want you faking an intubation till you make it. Like, that's no bueno. We can't do that. But what we can do is have that same person come forward and say, hey, Dr. Collins, you know, we're trained to do intubations. We don't do RSI right now, but I'm still just terrified of that cardiac arrest patient that we're not getting definitive airway. I need to do an intubation. Well, what do I do about that? If this is my paramedic, I'm like, hey, that is a great concern. Let's figure out some ways to make you feel more comfortable. You know, we have these mannequins. We can help you do intubations on those. You know, let me talk to the nurse anesthetist here. Maybe they'll take you back to the OR and let you practice on it, or like get some experience with them when it's in a controlled environment where the patient's adequately sedated and they're saturating okay. Or let's find an adjacent facility that might be willing to take a paramedic and get you some more intubation experience. And let's like hammer out the techniques more. Walk me through how you would do an intubation. Because the only way that you're going to get better is by finding the resources to make you better. You can read a textbook all you want. You can read through the protocols all you want. And you might be able to spout it off like that. But let me tell you, the first time that patient rolls into an ER or into a trauma bay, or you're out in the field and you're seeing those apneic respirations, they're satting 50%, turning blue, all that's going to go away. And the most important thing is that you want to develop the muscle memory to be able to do it without thinking. And the only way to do that is practice. And the only way to do that is to acknowledge that you are lacking in that area. And this is true of everything. You're not comfortable with IVs. Let's figure something out. You're not comfortable with ketamine. Let's walk you through it. Let's talk about different scenarios and what you would do with the ketamine in that situation. The best thing you can do for yourself is to advocate for yourself, because that's going to be a better outcome for your patients that you come across.
Is it okay to be wrong?
Yes. Like, that is the biggest misunderstanding in medicine, I think, for the layperson. We are not machines. We are not robots. We are not vending machines. So we're not just there to write medications and give them to you. We're not just going to do a bunch of random labs and tell you what you have. There is a rhyme and a reason. There's a reason that medicine is still called a practice. Like, there is no hard and fast science. Like, things change all the time. Like, I remember in med school, I forget the actual percentages, but it was like 50% of what you've learned is going to be wrong. 20% of it's going to be about the same. And then 30% of it's going to be different, or it's going to be more expounded on. So it is absolutely okay to be wrong. Where it's not okay is when you're actively defending why it was right. And that, I think, is like one of the biggest sticking points for medical directors, for the ambulance managers, is the person that comes in and says, I gave this medication, a bad outcome happened, but I would do it again. Or I was completely in the right for doing it, even though it violated the protocol. That's where we struggle. If, let's say, Phil, you come in and say, hey, Dr. Collins, I had this patient. I gave him ketamine. We had an IV in place. I might have pushed it a little too fast. They got apneic, and we had to intubate the patient in the field. What could I have done differently? Or what did I do that caused that patient to go apneic? Those are two very different conversations. Or let's say, you know, this patient came in, I pushed this med out of panic because I didn't know what else to do. And now I've learned that this is contraindicated because of X. Okay. Let's talk about that. Let's talk about why that's contraindicated. Let's talk about why you'll never do that again, because this is a learning opportunity. It's kind of funny because in medical school and in residency, you get told a lot that humans are really hard to kill. And it's true because our body is designed to be very resilient to stressors. So, messing up a medication 99% of the time is not going to kill the patient, but we could still have bad outcomes. We could have complications, and we need to talk about that when we screw up, and we need to own it. Yeah, I gave that wrong dose of medication and the patient felt dizzy or sick for a while, and I apologized to them for that. And now I learned to never do that again, or I learned to double check my dose when giving X. There's nothing wrong with being wrong or making a mistake. What's wrong is when people decide that instead of owning up to it or wanting to learn from it, they just double down and dig in and say that everything they did was completely blameless.
Just going back a little bit to what you said earlier, who are your mentors? Who do you listen to? Like, there'd be people listening to our show, right? This show, but who do you listen to? Like, where do you get your foam?
So it depends, first of all. I have a lot of mentors. So a little bit more background on me, just because we've been talking about stuff, is that, I'm board certified in emergency medicine. So I've got mentors in my residency program that were kind of my people to go to. Dr. Kat Parker, she's now the residency director for Mizzou. She was my go-to. She was fresh out of residency when I started. She was kind of one of my first attendings. And by the time I was done, she was one of the few people that knew that I was going to do rural emergency medicine. And so she took immense pleasure in whenever we had a sick patient come in, she's like, all right, Collins, you are in the middle of nowhere and this patient comes in. Tell me what you're going to do instead. And she had a field day with that. I love that about her because it made me start to think about, what do I need to improvise in these situations? And she's still one of the first people that I will call if it's the middle of the night or I have a really weird patient or something else just isn't making sense. She's one of the first people that I'll call when it comes to just general emergency medicine. If we're talking about EMS stuff, Dr. Josh Stilley, he's the EMS director for Mizzou. He does a lot of the Central Missouri EMS services. He has been instrumental in me just getting better at EMS. Like him recommending me to go to NAMSP, doing the medical director's course. If I've got questions on protocols or learning how to navigate people, like if there's just a difficult situation that comes up, he's like the first person that I'll call just about those types of things. I've made some contacts in Minnesota. Dr. Mike Wilcox is a big deal in emergency medicine. He's actually one of the old guard. I believe he's family medicine, but he commands a lot of respect because he's done EMS for years and years and years. And so he knows all the ins and outs of Minnesota EMS. So if I have a question about like Minnesota related EMS questions, I can shoot him a text at any time and he'll get back to me right away. I can give him a call and he'll let me know right away what's going on or what's up. So that's super helpful. If we're talking about like ultrasound, because I'm also ultrasound trained. I am the POCUS director for the University of North Dakota. I've got an arsenal of people that do POCUS that trained me in the fellowship for one, but then I've also got some other people that I've networked with that I can reach out to because POCUS is complicated, man. Like there's so many nuances. There's so many things. We talked about that we're going to be hopefully doing a little piece here with Kasha Hampton, who's a fellowship trained POCUS person. She's also fellowship trained EMS. Like she's got both worlds and she's a wealth of knowledge. Her daughter, Livia, is a wealth of knowledge when it comes to POCUS. Like you cannot have enough mentors when it comes to this kind of stuff. When it comes to just general medicine, just general being a good person, general education, because I love education. I love being an educator. I love doing sim. I love teaching medical students. I love teaching paramedics. Dr. John Allen, who just retired from UND, is a huge, mentor in my life because I'm going to be honest, when I finished residency, I had no intention of doing academia at all. Like I thought, I might go back to UND and do some simulations, or I might teach a lecture here and there just because I feel like I could do it better. like we all think, like I'm going to teach that topic better than whoever taught it back then. And next thing I know, I'm a very active faculty member in the Department of Emergency Medicine. But Dr. Allen is the person that facilitated that and nurtured me and really kind of taught me what it means to be an educator for rural, smaller medical school student education. I would say for anybody, the number of mentors you have should be limitless. And they should be specialized. You should have people in different areas of your life or different areas that you're interested in so that you can go to those people who are content experts of those areas.
You're a big bad attending now.
Sure.
You're a big medical director. I know oftentimes you have to get on the phone with people that you don't necessarily know. Are you still on the receiving end of some phone calls where you're kind of getting yelled at?
Yeah, it's mainly the ivory tower phenomenon. I won't say where we do our transfers because I don't think that's relevant, but I feel like there's still this ongoing issue, and I highly recommend people check it out. It's a lecture by Dr. Ken Milne. He does the Skeptics podcast for emergency medicine. He is a hoot. I've met him in person. I've interacted with him several times. He is a wonderful human. He does a great YouTube talk on what's called urban splaining. And I think that is something that I still struggle with a lot because there's some situations where I call level 1 trauma center. And I say, hey, I'm Dr. Collins. I'm working in this such and such a facility. This is the patient I got done, da 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 da. And then just to hear the annoyance or like the, well, have you done this yet? Or have you done that yet? Or, well, why haven't you done this? And then to like have to explain to them, okay, I'm in this town with this many people, with this many nurses, and I don't have X, Y, or Z staff. These are the procedures I can do. These are the medications I have. This is why I'm calling you. I think that is probably one of the biggest challenges, or I wouldn't say I've gotten yelled at, but I've definitely gotten that condescending tone from the receiving facility or the specialist in question that I'm asking something about. That's still very alive and well. When I was a third-year resident, we took those calls. Like, we were the ones that did the receiving transfers from other facilities. And I really learned to check myself because I kept reminding myself, these are the towns that I'm going to be going back and working at. So I need to give these people some grace. And I think that sometimes these level 1s, level 2s, they never worked at a smaller facility. They've never been at this place. So they don't know what I'm capable of. They don't know what I have. They don't know that I'm board certified in emergency medicine or that I'm a fellow of FACEP. Like, they don't know that stuff. So they're just assuming that I'm a Joe Schmo in the middle of nowhere who has medical school level knowledge, if not maybe primary care knowledge, and that's it. And so it's really hard to check yourself in those situations. I'm also one of those people that wants to play nice in the sandbox. Like, that's been my thing from day one. Like, when I got to Ortonville, I introduced myself to everybody. Like, I go and hang out with the rad techs when I have downtime just to talk nonsense about what we're doing or about some CT scan I want done of some obscure extremity because I find weird things to scan because I want to, or the patient needs it. I go hang out with lab, talk to them what's going on, figure out what kind of lab tests they're doing. Or if I have something really weird, like a really weird lab result, they'll call me and I'll go over and I'll explain to them, like, this is what I'm concerned about because of this weird lab test. I feel like rapport is so important, not just in your own facility, but inter-facility. It would be really nice if, like, the medical director of one ER should be pretty good friends with the medical director, or at least on good speaking terms with the medical director of the receiving facility, so that when these bad things happen, you can say, hey, my partner the other day had this really bad thing come in. There was clearly some breakdown in communication between the receiving ER doc and the doc at our facility. How can we make this better so this doesn't happen again? That's the kind of stuff that I'm really passionate about. And I just haven't really figured out how do we make a difference in that situation? Because I don't know. I don't know if there's a good answer. But I feel like this applies to everything. EMS to the receiving hospital, flight team to the hospital that's transferring to the receiving. There's breakdown in communication, judgment, and condescension in all of these areas across every dimension. Like, no one is guilt-free in this area.
What motivates you? What guides you? What keeps you stable? What keeps you from burning out?
I think for me, family is super important. So my wife has been my rock for years. We dated for a year or so, and then we got married just last year. She's an enabler, for one. She fully supported the podcast. She loved it. She loved the fact that people loved it, and she loves tracking the numbers because she just can't stop bragging about her podcast husband, which I don't see it that way, but I love the fact that she's always enabled whatever shenanigans I'm into, whether it's podcasting, ultrasound, teaching, locums. She's been instrumental to that. But she's also been good at saying, okay, David, you need to stop. You need to take a minute. You need to take care of yourself. You need to be here. You need to be present at home. I absolutely love that about her because she's been very good about that, because before she came along, I had a hard time stopping. Like, if I wasn't working here, I was doing locums or I was teaching or I was traveling. Like, I didn't really sit still. So, like, to have a loved one, in this case, my wife, to just say, hey, you got to check yourself. You need to settle down. We need to take a weekend to ourselves. That's been very helpful. Having a rock star family, my parents, my brothers, who have dealt with my situation for years, right? Like, you go to med school, you don't come home a lot. You go to residency, you don't come home a lot. You're an attending, you come home more, but sometimes you can't go to the family function or whatever. And so that's super helpful. My faith has been really critical to that as well, just because as a Christ follower, being a physician is all about service, right? Like, I don't go into a room and push an agenda. Politics is very raw for people right now because there's always agendas being pushed into medicine because of politics and vice versa. That is not what I'm about. What I'm about is I've been given a gift from my creator to use my brain and to use my hands to heal people or to give them guidance. And that is rejuvenating in itself in many ways because I know that I'm in the right place, I'm in the right time, and I'm doing the right things. The third piece, and I think it's the big three for sure, is teaching. I love teaching. I fell into teaching at UND and I've just gotten more and more lectures. I've gotten good feedback from students and from faculty. There's something to be said about, we do this stuff for so long and we just get so sick of it. We get into our routines and we go on autopilot. But to go back to UND, for example, and talk about sepsis, walk them through the pathophysiology of sepsis and give them like real cases that I've had and watching them poop their pants because what would I do? Because that's what I literally do is this is a scenario. What are you going to do? I'm not going to tell you what I did yet. You need to tell me on your current limited knowledge what you want to do. And by the time they're done, they're ready to go run through a wall and take on the world. That in itself is rejuvenating because you get to see the younger generations who clearly want to help people, who clearly want to understand the body and how medicine works and how to make a difference. And what better way to get that shot in the arm and go right back to taking care of patients or, teaching paramedics and going back to taking care of your patients. Like all these avenues that teaching allows, I think really, for some people, and for me in particular, really rejuvenates me and gets me excited about doing medicine again.
That's huge. Last question. Final thoughts to the rural folks, the rural EMS practitioners, the med student considering the next step, the folks that are like, I'm out here, I'm doing it. I'm on my ambulance in my 800 person town and I'm listening to the podcast. What do you want to say to the folks that are out there in all over the country in these places kind of doing this hard work?
Let's make some noise. And what I mean by that is patient care should not differ from a level 1 or like a urban suburban setting versus a rural setting. And I think that people that really care about their communities, that really care about their town, their ambulance service, they want to be the best version of themselves. And I find that most of them are just frustrated by the fact that they don't have the resource to do it. And I think the best way to make that difference is what we're doing here right now. I think, as I've told you before in private, Phil, is that I want to get this out to people where it would make a difference, where it will prompt discussion. We might say some things that are pretty controversial. Like POCUS is a great example where I think we get some people riled up pretty quickly. Part of why we do this stuff is that we want to inspire conversation, not just on the podcast, not just on the website, not just on Facebook or our Instagram or whatever other social media things that we make later. But I want this to be something where we can learn from each other, figure out how we can adapt practice to our respective communities, and give patients the best care possible. Because I think it is doable, not just because you're really smart and not just because you're really driven, but I think we have demonstrated just by talking today, ER doc who's emergency medicine trained, board certified, fellow of the American College of Emergency Physicians, went to a rural town and made a difference just by asking questions and presenting data. And I think the same thing can be said about people in small towns, in rural states, in rural parts of countries, just to ask the question, what do I have? What can I do with it? And how can I make a difference?
Dr. David Collins, thanks for sitting down with me on your show. On your podcast.
It's our show, Phil. If anything, this has grown exponentially in the last couple of months, I think, in particular. And that's what I want this to be. Like getting Reagan and Livia on this and doing their spiels, having more of you, having more of these sit downs. Like I think that you and I talked about, shoot us some questions. Like we could just do some rapid fire questions just on an off week where we don't got anything going on. This program was initially dedicated to my paramedics, and it still is. Like, we're still going to talk about protocols because that's what I'm here about. But the feedback we're getting, what we're hearing from other people is, give us some more of this other stuff. We don't know what you want if you don't tell us what you want. We've got email addresses listed on the podcast, on the website. There's a website where you can post questions. There's Instagram, there's Facebook. Find us on there. Shoot us messages there. I think right now all we have on Facebook are bot messages. So come on, let's get some real people talking back and forth. But yeah, like I would love to see this take off, not just in rural US, but rural Canada, rural Mexico, Eastern Europe, etc. Like, I just want to hear from you all. Like, I want to figure out how can we make your programs better. Obviously, everything I'm giving is not medical advice. Like, I can't say like take everything I say and just run with it. These podcasts are meant to inspire you to ask questions and figure out what you can do within the confines of your service, of your state, of your protocols, of your national guidelines.
Fantastic. Listen, for everybody listening, just so you're aware, stay tuned for an interview similar to this with Reagan, who you hear on a regular basis. I'm sure down the road we'll get with Livia. We just have to match up time zones. So that'll come through. If you have questions, if you have things that you want to talk about, like Doc said, please send them our way. Also, we are just a little commercial here. We're looking for people who are interested in talking to us about their service. Let us know where you are. Let us know what your service is like. If you're willing to give me a few minutes and just kind of give us insight into your world and what your challenges are. The more we know about each other, the more we can build these links. And please stay tuned for the episodes we have coming up. Thanks a whole bunch.
Thanks, y'all. We appreciate you.
I want to thank you all for joining us for this special episode of Medics, Musings, and Mayhem. And as Doc always says, may your mayhem be well controlled, full of teachable moments, but also provide you with the opportunities to provide your patients with the best care possible. Thanks again.